Hello, how you doing? I'm going to talk about schizophrenia today. It's kind of a hard subject, but it's one that you might need to know on the NCLEX. So we're first going to talk about the pathophysiology. It's a condition that has psychotic features and disordered thought process and a disrupted interpersonal relationships. It affects the client's affect, the way their face looks, the way they respond to whether it's good or bad, their mood, their behavior, and their thought processes. So the psychotic features include hallucinations and delusions, and I'm going to go into a definition of these and then how you treat them. And I've got notes that I'm going to glance down once or twice, sorry. So the definitions of hallucinations, it's a perception that involves the senses. It occurs in one of the five. There's no outside stimuli that exists that's causing this hallucination. It can be organic or it can be functional. So treatment for hallucinations is first I have to monitor the schizophrenic patient for the hallucination. I need to intervene if there's ever any one-on-one contact. I need to decrease the stimuli, whether that is to decrease the stimuli by moving things out or changing the environment the client's in, or moving them to another quieter stimuli environment. I need to avoid saying to the client that they're having a hallucination. In other words, don't confront them about it. Avoid touching them. Encourage them to express their feelings. What are they feeling right now? Are they scared? What's going on up here? And then attempt to engage them in a concrete activity during an active hallucination, getting them off of the hallucination onto something concrete. And then accept them. Don't joke about what they're doing, and don't judge the client for it. Then the other psychotic feature is the delusions. They believe events or situations or interactions relate to them. It's all about them. So how do we treat that? We interact with them based on reality, not based on what their delusion is. We, again, encourage them to express their feelings. We don't argue with them or try to convince them that their delusion is not real. We, again, initiate activities, but they're on a one-on-one basis. And I would alter the hospital routine at some points, if I can, by providing food that's packaged or canned, something that I couldn't have tampered with. And then give them positive feedback when they're doing the right things. So the physical assessment of a schizophrenic client, they're going to have a disheveled appearance. They can neglect certain parts of their daily routine, their hygiene, their eating, their sleeping, and elimination. They can be lost in thought about somatic complaints. Their motor activity, they can be catatonic, which means they don't move at all. They're stiff. Or they can be catatonic excitement, where they're moving really fast. Or they can be possibly immobilized. They could have an inability to respond to commands, or they could respond only to commands. This is a picture of a catatonic positioning. The motor activity can be repetitive or standardized movements. They can have a waxy flexibility. Their motor activity may be increased. It could be agitation, pacing. They could have an inability to sleep, loss of appetite, weight, and they can be very impulsive. Got to think on your feet with these people. So emotional characteristics, they're actively mistrusting anyone. It doesn't matter who you are. You can be the most innocent looking person and they're going to mistrust you. Their view of the world is that it's threatening and it's unsafe. Their affect is blunted, it's flat, it's inappropriate. So if you tell a joke, they're not going to respond on their face. And I'm not telling you to tell a joke, but if somebody did tell a joke in their presence, they would not respond to it the correct way. They wouldn't laugh. They would probably cry, or they wouldn't respond at all. They would have a blunted effect. They may display a range of feelings such as ambivalence, helplessness, anxiety, and the list goes on. Here is a normal effect, a constricted effect, and a blunted effect for winning the lottery. Can you see the difference between the normal and the blunted? It is really huge. This is an affect of no response to the fact that they just won a lot of money. So they have compulsive rituals. They repeat the same activities over and over in an attempt to solve problems with what they're feeling, not what they're thinking. This is totally different than OCD, because OCD is all about their emotions. Schizophrenic is all about, oh, I got it backwards. OCD is what they're thinking. Schizophrenic is their feelings, okay? Then overcompliance. Instead of just responding to what you instruct them to do, they do it exactly. Can be frustrating if you give them an instruction and you didn't give them all the steps and they do exactly what you say. Abnormal thought process. They have an impaired reality. They have fragmented thoughts. They even can have thought blocking where they suddenly have an inability to complete a thought. And then they start talking about an unrelated topic. They can have loose associations. It's illogical. It's haphazard. It's confused. They can have echolalia, which is pathological repeating of another's words. This drove me absolutely bonkers. I didn't let the patient see it, but it drove me bonkers. I used to work in a psychotic building, and you'd take the meds into this one patient, and he did it to me every single time. I walk in, I'd say, here's your meds. And I'd say, please take your meds, please take your meds, please take your meds, please take your meds. And he would just keep repeating back to me what I was saying. So other abnormal thoughts would be the neologism, which is made up words that have meaning only to the client. So they're going to say words that don't make sense to you. When you hear this, you need to ask them, I don't understand what you're saying. They can have magical thinking. They can have the inability to conceptualize meaning in the words or thoughts. And then abnormal thought processes, the inability to organize facts in a logical manner. They can have delusions associated with those thought processes or the content. Language and communication disturbances, and these are related to thought processes, the inability to organize speech. Then examples of language communication disturbances, allegory, which is poverty of speech. It's reduced volume or lack of unprompted comments, or their overly brief answers. So they could just not give you the strong volume you need to be able to hear it, or they'll give no comments at all, or they'll give an overly brief answer. Associative looseness is when it's disjointed mental threads that tie thoughts logically together. And then clang association, it's repetition of words or phrases that sound similar, but are in no way related. So another kind is the mutism, where they can't talk, the echolalia, which we've already talked about. We've already talked about the neologism. It's newly devised words, especially for that client. They have pressured speech, where they force words out really quickly and you can't really keep up with what they're saying. And I'm not even doing it as fast as they will do it. Religiosity, where they're preoccupied with religious ideas. Tangentility, where they digress from one topic to another and not completing the thought ever. Verbogeneration is the repetition of words or phrases without a purpose. Word salad is a form of speech in which the words or phrases are connected meaninglessly. So what do we do for these schizophrenia patients? We provide a safe environment. You maintain that for the client and yourself and the other clients around. Their behavior, you need to set limits. If it's going to hurt themselves, you, or somebody else, you need to assess them for physical needs. Remember, on Maslow's, the psych is way up here and the physical needs are way down here. So if there's a physical need, you need to deal with it first. You need to monitor their thought process for being altered. You need to maintain those ego boundaries. And the big one is avoid touching the client. Don't be overly warm in approach with this client. Be more neutral. You don't want them to be suspicious of you. You need to establish a daily routine of how things go. Help them out with their ADLs, especially grooming. Help push them, I think that's the wrong word, help assist them to get into doing the grooming on their own. Limit the interaction between you and them, but make sure you have brief and frequent contact. So don't stay in the room a long, long time. Keep it brief and frequent that you're in there. Tell the client when you're leaving. Tell the client when you don't understand what he or she is saying. When the delusions or hallucinations occur, don't go along with them. Reorient them as needed. Help the client to establish what's real and what's not real. And stay with the client if they're afraid. Remember, we said we were going to encourage them to talk about their feelings. I'm going to speak to the client in simple, direct, and concise manner. I'm going to remove from the group if their behavior is too bizarre, if it's disturbing, or if it's dangerous to someone. I'm going to set realistic goals for these clients. And then initially, I'm going to not offer to let them make choices, but gradually I'm going to assist them to make their own choice, their own decisions. And then lastly, I'm going to decrease the excessive stimuli. And I've already said, if that means removing the stimuli from the environment they're in right now, then do so. If not, then move the patient to a different environment. Monitor for suicide. Are they suicidal? And then assist the client to express themselves through alternative methods like music and art, therapy, and writing. Like I said, schizophrenia is not an easy topic. It's some of those words, I probably butchered them, but the idea is you just got to stick with the program as far as how you approach them and what you do with them if they're in a delusion or in a hallucination. I hope this has helped. See you around. Bye-bye.